Okay, we're going to talk about severity scoring in chronic disease. You have to know how bad somebody's existing diseases are before you can layer a new illness over the top of them. So you have to know severity scores in order to work out what to do with somebody. A patient who's got end-stage lung disease, who gets appendicitis, who's not fit for an operation, is going to die from that appendicitis. So if you don't know how bad their lung disease is, if you don't know how to measure that, then you don't know how to treat a patient properly. So severity scoring is fundamental to patient management. There are a number of different um, organ systems, so we'll go through them bit by bit and have a look at the severity scores. I've never seen these scores all put together in one place. So I've done that in this document, and I'm going to try and work out how to affix that to a YouTube video so that the document can be discovered. Um, Although it's available, I mean, here you can flick through the video and find it. I'll start off with neuro because a person's neurological condition is the basis of a lot of the other conditions. If they've got, I like to think of these in terms of yellow, orange, and red. If they've got a red brain, if they've got a bad brain, regardless of what it's due to, the will you go on with treating all of these other sort of things? A person who's got end-stage dementia who comes in who needs ventilation in Australia won't get offered ventilation. Um, and A person who's had a severe stroke or you can't thrombolyze people who have had severe strokes. You can't ventilate people who are incredibly frail because they don't get off the ventilators. Um, so I realise that that's done differently in some countries in the world, but that's the way that it is in Australia. Um, so we'll talk about. So I think neurology is the most important um, organ system, but cardiac, respiratory, liver, gut, renal. Frailty is a mortality indicator. Cancer is important. People often miss at the what stage somebody is cancer is because they think it's metastatic and that's the end of them, and it's not true at all. And obesity is clearly a mortality indicator. Um, Trying to keep these things reasonably simple is important because if you're over perfectionist about these scores, then it's going to be too difficult to use severity scores on a routine basis. Severity scoring dementia, there are a number of different scores around. People often use Mini-Mental. Um, the Dementia Severity Rating Scale is a 7-page document. I've pulled this document together into examples of mild, examples of moderate, and examples of severe. And there are numbers that go along with this, so you can actually work out whereabouts people fit. But it's handy to have it in a one-page document, because you can discuss this with the family and with the patient and show them, if they're up here, it's sort of, everybody knows that dementia is a progressive disease. And so it implies that, they may get down to here and they may get down to here. Interestingly, only 25% of people in Australia die from their dementia. Most people die from other causes. Cancer and vascular disease are the common things. But it's worth knowing that it's a progressive disease and that one day people may get down to the point where they are confused about basic things. They're always confused about time and place. They're unresponsive, and eventually they become totally dependent for their care. Stroke modified Rankin score explains, if somebody's got a moderate disability, they require some aids, but they are able to get around by themselves. People with more severe disabilities have problems when they, if anybody who's had a moderately severe stroke then needs an anaesthetic, that can be a real problem. Um, um, Obviously important to include in that what their comprehension's like, if they've got an aphasia or a dysphasia of some sort. They also change over time. So how somebody is when they're acute and in hospital, or whether they've had a remote stroke, 10 years ago. Um, Obviously, these things change a little bit. Parkinson's disease, they're staging for Parkinson's. Um, Multiple sclerosis is not dissimilar, related basically to their ability to ambulate. Somebody who's got mild disease is pretty much fully ambulatory, can walk 500 metres. Somebody who's got moderate disease may have constant supports. Um, um, and people who are unable to walk for anything more than short distances, you would say, are probably severely um, um, affected by their MS. New York Heart Association classification for heart failure has come under question a little bit in recent times, but there's not an awful lot else to measure it. We know that people who are admitted to hospital with heart failure have a 50% 12-month mortality. So when you start to get down to these sorts of levels, the moderate and the severe, if you get hospitalized, then that's a bad thing. It's probably useful to be able to say whether somebody has mild with no limitations, whether it's still mild with slight limitations, whether they've got marked limitation, or whether they're actually severely breathless. It's incredibly useful to be able to say that, because it tells you how they're going to cope with new acute illnesses, and it's a mortality indicator. The clinical indications, implications of heart failure. There's a treatment ladder, which tells you something about whereabouts people are at. People who are on neprilysin inhibitors, like sacubitril, you have to have grade 3 heart failure or worse. So it tells you they've got pretty significant heart failure. People who need biventricular pacing, because dysynchrony, if the heart's pumping, if they've got a bundle branch block, if that's going to affect their heart failure, that tells you they've got severe heart failure. People don't usually qualify for a defibrillator unless they've got pretty significant heart failure, and it does change their mortality, improves their mortality. New York Heart Association is ADLs based. BNP levels haven't proven to be particularly useful. They're more useful in the same patient over time, and ejection fractions, again, are useful for those people with systolic dysfunction. A little bit about mortality figures. The mortality from ischemic heart disease is often from acute rather than chronic. All right, so that's cardiac. Respiratory. This diagram bamboozled me for a while, until I really realized what it was all about. They use symptoms as well as spirometry to measure a person's degree of lung disease. So there was a weak correlation between FEV1 alone or between symptoms alone. So that's why they do a combination of them. And a lot of stuff, a lot of numbers, and it gets complicated. I mean, the degree of their breathlessness, again, the Medical Research Council's table of dyspnea is obviously a symptom-based test. My severity suggestions would be people with mild COPD have few symptoms and their spirometry is pretty good. People with severe symptoms are people who get hospitalized. People with CO2 retainers clearly are hypoxic on room air. So if you need home oxygen, if you're a CO2 retainer, you probably need home oxygen. If you're on any sort of ventilation, if you've got right heart failure, if you're breathless showering, if you have any exacerbations of breathlessness which are not related to infection, these are all signs of severe lung disease. And interesting, looking at the mortality rate, People who've got severe COPD follow this line. People who've got mild follow this line. The people who are moderate, whether it's their symptoms or whether it's their spirometry that's bad, seem to have a very similar sort of outcome. So I think it's quite a useful way of measuring how bad their lungs are. Liver disease, Child-Pugh, and MELD has been around for quite a long time, and they give you some degree of mortality indication. They weren't actually designed for that. They were designed, one was designed for, I think it was for mortality after TIPS procedures or something like that. The CLIF, which is chronic liver failure, looks at the number of other organs that are failing, and seems like it's actually quite a good indicator for, I mean, when somebody's got liver problems alone, then they have significant liver disease when they've got ascites or when they've got jaundice. But when they start getting encephalopathic, or when their renal function starts to fail, or their bone marrow starts to fail, then you know that they're really in big problems. And that's probably the long and short of the liver disease mortality indicator. It's on MD Calc if you've got access to that on your phone and online. Goes through Child-Pugh and MELD. That's right, it was survival for patients undergoing portosystemic shunting. And it gives you a good degree of mortality. So I mean, at least if somebody's using some mortality indicator, then you know how bad their liver disease is. There was a musician locally who died from a AAA a number of years ago. He, a very famous Australian musician, and it didn't become apparent that his hard rocking lifestyle had completely trashed his liver, and he had quite significant liver disease, and he actually his problems were coagulopathic after his aortic repair. It's a great shame. He was a great musician. Nobody knew about that. I don't know that anybody had ever measured it. Renal disease. So blood tests, you can't diagnose renal disease just by blood tests alone. You've got to have some evidence that they've got bad kidneys. Either the kidneys are leaking, or on imaging you can see that they're starting to get shrunken and scarred. So this is the likelihood, depending upon how leaky their kidneys are and what their blood tests are like, that they're going to end up with chronic kidney failure and end up on dialysis. So the leakier they are, the more problematic, and the worse the blood tests are, obviously. The frailty score, many people will have seen the Rockwood frailty score. I like it because it's visual, and it's very easy to see whereabouts somebody fits. If they've got a stick, then they're vulnerable, but they're fine. If somebody is moderately frail and they can't really get out of the house without help, that person, if they fall over and break some ribs, or if they get pneumonia or things like that, there's a reason that frailty is a mortality indicator. So the yellow, orange, and red, like mild, I thought came down to the mildly frail. Moderate was somebody who needs a walker, and really that's about it. And then the severely frail, somebody who's completely dependent, and somebody who's bedbound obviously has severe frailty. Cancer is. I walked into the emergency department one day, and there was a guy who had metastatic cancer who had septic shock, and the night duty team had decided that because he had metastatic cancer that they weren't going to be aggressive with his treatment, which looking back is horrifying, because he was only early in his treatment. He had only just been diagnosed with metastatic disease. And I think if it was lung cancer, I think if you got metastatic lung cancer, your life expectancy would probably still be several years. So he wasn't treatment resistant, and he certainly wasn't palliative, which is almost what they've been doing. So knowing that there are life curves, and knowing sort of whereabouts on those life curves people are, is incredibly important from a cancer point of view. Um, the type of cancer changes the outcome. Um, Melanoma, for example, used to be a death sentence. A friend of mine's mum died from melanoma about 20 years ago. But in quite a number of instances now, it's curable. Um, so that's cancer. Obesity, this is the relative risk to life. So when people get up to, where are we? Above 30, you start to get into the super morbidly obese, and certainly above 40 is super morbidly obese. And the death rate for these people rises. There's a reason that you don't see people who are 180 and 220 kilos as 70-year-olds, is because they've either lost weight or they've died. And that's not a judgment, that's just the reality of the situation. We don't really routinely think of obesity as the mortality indicator that it is. Um, um, the causes of death in Australia, 2018 was the most recent figures that I had access to when I was writing this. People die either of ischemic heart disease or cancer. Dementia is not that uncommon, but a lot of people don't die from the dementia, they die with dementia. Interestingly, um, ischemic heart disease and cancer are below intentional self-harm in terms of the years of potential life loss. This is a lot of young people. The ACE scores are not that well known, but it's adverse childhood events, and the adverse childhood events explain why people eat too much, get diabetes, get overweight, and then get all of the metabolic complications of overweight with hypertension and vascular disease. Hypertension, hyperlipidemia, diabetes, and then they go on to develop vascular disease, and or they smoke and drink alcohol, and so they get all the cancer diseases. There is no money spent really, and there's a little bit of lip service, but almost nothing's talked about prevention of all of these sorts of things. We live in a world where it's okay just to ring the Pavlovian bell and make people salivate and sell them whatever you damn well please, and hang the consequences. Anyway, that's a rant for another day. I think that's probably about it. So let me know what you think about that. If we severity scored people more, we would have a better idea about whereabouts they fit in the how sick they are ultimately. I'm in the process of doing a severity scoring graphic at the moment. So, I mean, this guy, I've always liked these transparent blue people. Imagine if you could pull up a graphic where you could say, oh, he's got a heart problem. And you could click on it and it told you how severe his heart problem, whether it was yellow, orange, and red. In 1 second, you could tell what was going on with this person. This is a 46-year-old who's come in, who's in cardiac arrest, and you click on his picture and there he is, and he's got a red heart, and you go, oh, okay, he's obviously had a heart problem. If he's completely normal, then that tells you something. If he's got a red brain, it's like, why is he, is there something here that's contributing to it? If he's got red kidneys, your first question is, well, what's his potassium? Has he had a hyperkalemic arrest? So the ability to graph these things really allows you to then display the severity scores in a graphical nature. It takes us from the DOS days. I don't know if anybody remembers, from when you used to have to write out y, if you want to move on to the next level, you had y equals 1, n equals 2, or something like that. Nowadays, you just click on something and you can make it happen. So this allows you to represent a patient's organ diseases. And you can imagine if you had 1 for mild, 2 for moderate, 3 for severe, you could actually give a patient a number and say whether they're a 2-pointer, a 4-pointer, an 8-pointer. A person who's got 8 points for chronic disease is going to be in trouble if they get sick. It allows you to measure the complexity of that patient compared to other patients and look at their mortality numbers and actually be specific about those numbers. It allows you to measure one hospital against another or one ward against another. If you've got a ward where all of the patients, like the orthopedic ward for old people, if you break your hip and you've got a multitude of chronic diseases, then that those people have a high mortality rate. So it allows you to get a much better measurement of those, and therefore to prognosticate better for patients. So anyway, I think that's about at the end of the recording. You get the idea of what this is all about. If you've got any questions, you could email me. You saw my email address on the previous, where are we? This one here. Okay, thank you.